So now moving on to neuromuscular junction, that is the most important topic of the entire chapter. Alright, this is asked in your theory as well as in your vivas. So understand this topic very carefully. It's very easy, there's not much complicated details over here. It's completely logical. Alright, so starting over here, we start with the topic's name, that is neuromuscular junction. What does it mean? Neuromuscular comprises of two words, neuro and muscular. Neuro and muscular. The neuro means the nervous part and the muscular means the muscular part. So it is the junction of the nerve and the muscle. It is the part where the nerve meets the muscle. Alright. So this is a diagrammatic representation. This is the nerve, this is the muscle. Alright. So this part is the muscle, this is the nerve. The main components of the neuromuscular junction are presynaptic, synaptic and postsynaptic. I suppose you all know what synapse is. That is a junction between two parts. Alright. So this is the synapse that takes place. And this part is a synaptic cleft. Alright. This part is a synaptic cleft. The presynaptic part is the part that contains the nerve. The nerve has an axon terminal and a synaptic knob. Alright. The axon terminal is lined by myelin sheath and everything. This is a synaptic knob. Alright, the synaptic knob is nothing but an enlarged part of the terminal part of axon. Alright, the synaptic knob contains something. It has these receptors, these channels rather. It has channels for calcium. Yes, calcium channels. It has mitochondria. It has these vesicles that contain acetylcholine. Acetylcholine is nothing but a neurotransmitter. Alright, and these vesicles is where the neurotransmitter is stored. Okay, then comes the postsynaptic part. The postsynaptic part is the muscular part and it is the sarcolemma of the muscle fiber. Okay, so now what exactly happens and how the entire event takes place. Okay, so the first thing that happens is the arrival of a nerve impulse. So the nerve impulse arrives at the synaptic knob. Alright, the arrival of nerve impulse at the synaptic knob triggers these calcium channels. These calcium channels are usually closed, but when the impulse arrives, they open up. Alright, these channels open up and there is an influx of calcium ions from the extracellular fluid. Okay, the calcium ions flow in from the outside. This flowing in of calcium and its binding to these vesicles cause the release of the neurotransmitter. Okay, so I'll just show you over here magnified how this actually looks. Okay, so for example, if this is the neurons and this is the muscle with these clefts, these are the vesicles. Alright, so this is the vesicle. Okay, and this is the presynaptic part, this is the postsynaptic part, and this is the synaptic part. Alright, these clefts, they contain something known as acetylcholine receptors. These acetylcholine receptors are more technically called cholinergic receptors. These cholinergic receptors are of two types, muscarinic and nicotinic. The type of receptors present in the NMJ or the neuromuscular junction is nicotinic type. Alright, so these are present on this muscle layer or the postsynaptic part or the motor end plate, as we call it more technically. Alright, so the influx of calcium and binding of calcium to this vesicle causes the movement of vesicle towards the membrane of the new axon on the synaptic knob. So what happens, this vesicle moves over here and it binds with the membrane and it opens up and it releases its constituents outside. And what were its constituents? Acetylcholine, the neurotransmitter. Okay, so if you recollect from our video on vesicular transport, we said this is called exocytosis, and this is of two types, constitutional and non-constitutional. This type of exocytosis that occurs at NMJ is constitutional exocytosis. Alright, so constitutional exocytosis of these vesicles occur and the acetylcholine is released in this synaptic cleft. The acetylcholine binds with these acetylcholine receptors. or the cholinergic nicotinic type of receptors. Alright, two molecules of acetylcholine bind with one receptor. I'll repeat again. Two molecules of acetylcholine will bind with one acetylcholine receptor, and this binding of acetylcholine to acetylcholine receptors initiates or opens up the ligand gated sodium channels. The ligand gated sodium channels are opened, which means that the sodium that is present in the ECF will move in. The sodium moves in. This movement of positive ions from outside to inside causes depolarization of the membrane. That is, the motor end plate is depolarized, and this is called end plate potential. This end plate potential is of less magnitude. On one stimulus, this magnitude is very less. Repeated stimulus causes more release of acetylcholine. More acetylcholine is released, so more sodium channels will open up. More binding of acetylcholine to this cholinergic receptors increases the opening of sodium ligand gated sodium channels, and the sodium influx increases, the depolarization increases, and the magnitude of end plate potential increases. This end plate potential, when increases beyond threshold, the action potential is then transmitted across the entire membrane. Alright, so coming back over here, I'll just show over here what I explained again in a much simpler way. Again, so this acetylcholine is released over here, sodium influx occurred, and there is depolarization and end plate potential is formed. So end plate potential is formed, and when this end plate potential reaches threshold stimulus or threshold level, there is a generation of action potential, and this action potential is then further transmitted across the sarcolemma. Alright, from the neuromuscular junction, it is transmitted across the sarcolemma over the entire muscle fiber. Alright, and what happens after that, we'll see it in the forthcoming videos in the excitation contraction coupling part. But we are not done here yet. There is still much remaining. Okay, so now again I'll just draw this part again over here. So this is this are this. So these are the clefts in the muscle membrane. This is sarcolemma, this is the neuron part. Alright, so forgive my drawing, it's very bad. Okay, so this, now what we saw were acetylcholine is released, it is bound to the receptors. Now what happens? Apart from the cholinergic receptors on the muscle layer, there is something else also present. There is a particular enzyme called acetylcholine esterase. The acetylcholine esterase enzyme is present. What does acetylcholine esterase do? Acetylcholine esterase breaks down the acetylcholine into its two components, acetic acid and choline. Alright, so it breaks down acetylcholine to acetic acid and choline. Alright, so these two components are again free. Now what happens? This choline is reabsorbed by the neuron. This choline is reabsorbed and it binds with acetic acid inside this synaptic knob and enters the vesicle for its reuse. Alright, and acetic acid is just thrown outside. Okay, so what is the importance of acetylcholine esterase enzyme? This makes sure that the stimulus or the transmission is transient and it is not continuous. If acetylcholine esterase were not present, the acetylcholine would be bound to acetylcholine receptors permanently, and the contraction of muscle that occurs due to this would be permanent. What does that mean? That means if you contract your muscle once, for life your muscles would be contracted like that only. Alright, so we don't want that. So in order to make that synapse available for reuse, you have acetylcholine esterase enzyme. Alright, so this is about the neuromuscular junction. Again, let me summarize it for you, how the events or the changes in the, or what are the sequence of events. Okay, so let me just get this out of the way. So what happens now? Come over here and we'll see what happens. Okay, so first thing that I said was arrival of impulse. There is arrival of impulse. Impulse arrives. Then what happens? There is increase in influx of calcium. Alright, there is influx of calcium. This influx of calcium is followed by release of neurotransmitter. Okay, there is release of neurotransmitter. The neurotransmitter binds with its receptor and causes increased influx of sodium ions. This increase of influx of sodium ions causes depolarization. Depolarization causes formation of end plate potential. So end plate potential is formed, and if it crosses the threshold, it generates an action potential. Alright, so this is the scheme or the events how the neuromuscular junction, at which the neuromuscular junction takes place. Alright, so there are certain disorders in which the normal functioning of neuromuscular junction is affected. The first type is the myasthenia gravis. Okay, so let's discuss myasthenia gravis over here. So first we discuss myasthenia. Myasthenia gravis. So what happens in myasthenia gravis? Myasthenia gravis is an autoimmune disorder. What does that mean? Our body produces antibodies against our own self, our own cells. Okay, so what does in myasthenia gravis antibodies are produced against what? So if you recollect, I said there are acetylcholine receptors in this motor end plate. This acetylcholine the antibodies are formed against this acetylcholine receptors. So what happens is, in this is the motor end plate and these are the acetylcholine receptors. There are antibodies formed. These are the antibodies which attack these acetylcholine receptors. They attack these acetylcholine receptors and they decrease their number. How? These antibodies are, if you can say, they mimic the action of acetylcholine. They bind with these receptors, and the binding of this the antibodies with the receptors is not transient as we saw in acetylcholine. It's permanent. The permanent binding of these antibodies against these receptors make it unavailable for acetylcholine. Okay, so but one more thing, binding of acetylcholine to these receptors elicits a response. Binding of these to these receptors does not produce a response. Alright, so when these antibodies bind to them, there is something called down regulation that occurs. If there is a lot of stimulus given to a receptors, the number of receptors decrease. This is a normal physiological response. This is called down regulation. Alright, so this is the down regulation of these acetylcholine receptors occur, and the number of acetylcholine receptors go on decreasing. Alright, so the number of acetylcholine receptors decrease. So what happens is that whenever acetylcholine is released, it does not have the receptors to bind to, so the impulse is not transmitted perfectly. So this is how the etiology or the cause of myasthenia gravis is explained. So now what are the features that we commonly see? We commonly see in such patients that there is easy fatigue. You can understand quite easily that if acetylcholine receptors are not present, the impulse generated thus it is not transmitted properly, so the muscle is not contracting properly, and thus the muscle is getting fatigued more easily because it does not have the enough stimulus for the contraction. Alright, so there is fatigue, And there's a particular demographic seen in myasthenia gravis. Women are affected more than the males, alright? And in early onset of myasthenia gravis, or early onset, I mean the early stages of myasthenia gravis, you observe ptosis and diplopia. What do you mean by ptosis? Ptosis is drooping of eyelid, alright? So, for example, if this is the normal eye, in ptosis, what happens is the eyelid drops down. That means this drops down and it covers it like this. So somewhat like the eye size as seeing decreases. That's somewhat what ptosis means. Alright, so ptosis is seen because in myasthenia gravis the main organs that are affected are mainly the eye. Alright, and what happens in progressed state? In progressed state, if there is involvement of the respiratory system, it can lead to respiratory failure that can lead to death. Alright, and this is what happens in myasthenia gravis. So how do you treat this? To treat myasthenia gravis, you give them anticholine esterase drugs. Okay, so the drugs which inhibit the activity of acetylcholine esterase are given. Why? As we saw earlier, acetylcholine esterase degraded acetylcholine to acetic acid and choline. If you give an inhibitor over here, this won't take place. This reaction won't occur. That means acetylcholine, the concentration of acetylcholine would increase. The increase in the concentration of acetylcholine is something that, so this increase in the acetylcholine is something that we want. Why? This increase in the acetylcholine would mean that the acetylcholine would bind till more time with these receptors and would elicit a greater response. So continuous stimulation of these receptors can give you a response, but if can give you a response, that is exactly what we want. That is what is not taking place over here, and that is what we are doing by giving these drugs. So what are these drugs name? They are physostigmine, pyritostigmine and neostigmine. Okay, you'll learn this in second year pharmacology also, but this is good to know right now in the first year also. Okay, so this has happened, and there is some other drugs also known such as immunosuppressants, that are glucocorticoids, to reduce the immunity of the person. Thus autoimmunity is also reduced. It's quite risky to give immunosuppressants and steroids, but it's some kind of bargain that we have to do to treat it. Alright, then there is something known as plasmapheresis. It's not quite appropriate treatment for it. In plasmapheresis, you completely change the plasma of the patient. You transfuse new plasma to make sure the entire acetylcholine antibodies that are present in the blood go away. But that is something that is not commonly done because it's much more difficult, and not a good rate of success for it. Okay, there is then there is one more disease called Lambert-Eaton syndrome. The Lambert-Eaton syndrome. What happens in Lambert-Eaton syndrome? Like in myasthenia gravis, the number of acetylcholine receptors were decreasing. In Lambert-Eaton syndrome, the calcium channels present in the synaptic knob decrease. Alright, so this is the main thing that occurs in Lambert-Eaton syndrome. The rest of the symptoms are much more similar, except one distinguishing feature in between both of them. In myasthenia gravis, when there are repeated stimulus applied, the response elicited decreases over time. Because, okay, so that is something that I explained already. I won't explain it again. In Lambert-Eaton syndrome, what happens when you apply continuous stimulus? When you apply continuous stimulus, the response increases. Okay, so because if you apply continuous stimulus, more calcium ions flow in, more acetylcholine is released, and more entire thing is increased. So that is why Lambert-Eaton syndrome, the response increases over time. Okay, so that is all about neuromuscular junction, and with that I would end this video. I hope this made sense. Now you can go back and refer to your books. I'm sure you'll understand this much more better, and I'll see you in the next one.